And I'm going to run straight on just to introduce our first speaker. Detlef was originally from Germany, but has worked around the world, actually, in North America, and has been at Great Ormond Street as professor of pediatric nephrology for quite a long time. Must be 15 or 16 years, I think, Detlef. And what an amazing time to move into pediatric nephrology with an interest in genetics. And Detlef has discovered several diseases and described many more facets of a number of the other ones. And he wrote a review recently on tubular disorders, just last month, I think, which has about 60 diseases in it, which is probably more than most adult nephrologists think about in the average month. Detlef, tell us the golden nuggets about distal renal tubular acidosis in the young.
Yeah, thank you for that very kind introduction, Neil. So I'm going to talk about distal RTA, and I was told I need some questions. Hold on, let me just see that I can advance the screen here. So there we are. Here's the first question. I'm not going to provide any answers. You can just think about it yourself.
Oh, no, Detlef, we've got modern technology here in the South. We are going to use Slido for this. So you can say...
Yeah, but the Slido comes at the end, because I will bring these questions back in at the end. So this is
you want to make sure that they're listening. Okay.
Exactly.
You're being kind. I would have hammered them, but okay, we'll leave that with you.
We're kind here in London. So what is the clinically identified best form of alkali supplementation in distal RTA? And you have these various forms of bicarbonate and citrate, and you can have the various combinations. And then here comes my second question. How much alkali supplementation is recommended and at what frequency? Now, this is a confusing question. 2 to 5 milliequivalents per kilo and 3 doses, and so on and so on. So these are some things that you may want to just listen out during the talk. And I'm just going to start with a patient, a typical patient, a 6-week-old baby referred for failure to thrive. This is absolutely typical for distal RTA. Failure to thrive is the classic way how they present, and then somebody takes bloods. Was born full term, normal birth weight, normal pregnancy, failed the newborn hearing screen. The genetically attuned will already recognize which gene is most likely involved here. And now at 6 weeks, she is less than birth weight, but otherwise the examination is unremarkable. And then she has these laboratory investigations, and you notice some signs of likely dehydration, hypokalemia, acidosis, with a bicarbonate of 10 and a pH of 7.2. And then the first step you always do, of course, you all do, I'm absolutely sure, you calculate the anion gap, and it's 10, and that would be normal. And then you look at the urine, and of course, if you're acidotic, you would expect your kidneys to try to get rid of acid, so make a very acid urine. And instead, we see an alkaline urine with a pH of 8, and the super nerds may want to calculate the urine anion gap. I personally actually hardly ever do that, but the vast majority of protons is excreted as ammonium, NH4+, which of course is a cation. So usually you expect a cation gap in the urine, a lack of cations. Here you can see the cations exceed the anions, so there's no evidence of ammonium excretion. Here's the ultrasound, and it shows some nephrocalcinosis, as I'm sure you all recognize. And then, so the diagnosis would be absolutely typical distal RTA, and because of the hearing problem, most likely this is ATP-V1B1. There's also no family history, so recessive form fits with this. And treatment, this is actually the key point of my talk. Distal RTA is a treatable disease. You just need to give alkali. You just need to balance the acid load that's coming in with the diet and that comes with the growing of your skeleton. And with that, Bob's your uncle. I promise this is my only molecular physiology slide in the whole talk. You will be relieved to hear. So we are in the collecting duct. Particularly, we are in the principal cell and the one that matters most, of course, for the distal RTA, the intercalated cell type 1. And you are secreting protons here predominantly via the proton ATPase, which is a very complicated protein, has, I think, 27 subunits or something like that. 2 of these subunits, the V0A4 and the V1B1, have been associated with distal RTA. So pathogenic variants in these genes in a recessive fashion will cause distal RTA. Then there's the anion exchanger here on the basolateral side that brings the bicarbonate back into the bloodstream here, SLC4A1 or anion exchanger 1. And that is the gene encoding for this transporter is typically the cause for dominant renal tubular acidosis. Some variants are also recessive, but the vast majority of variants are dominant. And then very recently, there was this gene identified, FOXI1, which was already known from knockout mouse that it is causing distal RTA. And John Sayer and our group found some patients who were also having these. And this encodes a transcription factor that is responsible for the expression of all these transport subunits. Now, if you have a patient like that presenting to you, you want to tell the family what to expect. They will ask you, what's the long-term prognosis? And there's, because it's a rare disease, very little information available. So we endeavored to get more of that information, and together with the working groups for inherited kidney diseases of the ERA EDTA and the ESPN, we asked questions about demographics, treatment, kidney function, and complications. And the idea was, of course, to get as many adults involved as possible, because that will provide us with long-term information. And we were absolutely stunned and really pleased about the enthusiastic response we got to our questions. So 393 initial cases were reported. People were so enthusiastic that some of them actually put in cases that were not distal RTA, so we had to remove some of them, but we still ended up with 340 final cases, and we grouped them according to genetic status, either if the gene was known, or those who had a negative screening, so no pathogenic variant was identified in those 3 genes, or they did have incomplete genetic screening, so no genetic screening or just 1 gene was assessed. And this is here on the left side, age at presentation. And you can see that the recessive forms here typically present in the very first year of life. The earliest one is typically the most severe form, the ATP6V0A4. And then for the dominant form, SLC4A1, there is a wider spectrum. Quite a number of patients actually present in adolescence or young adulthood with stones with this disease. And then unknown, which probably is a mixture of all this, is throughout the entire presentation period here. Mm-hmm. And this is the age at last follow-up. And again, I told you we were interested to get as many adults as possible, and why this is still predominantly a pediatric cohort, median age here around early teens, late teens, early teens. There was actually a good number of adults in the group, so that we were quite confident we would get good information on long-term outcome. And before I come to that, here is just another case, just to keep it a little bit mixed here. 7-year-old boy, 7-year-old boy. So this is because of the age of presentation. He was one of triplets that were conceived by IVF, was born a little bit early, has sensory neural deafness, and has a cochlear implant for that, has a history of polydipsia, which is also quite typical for distal RTA, and has faltering growth. I told you before that failure to thrive is one of the most common presentations. But he's from a posh family, and they see private doctors. He goes to a private endocrinologist on Harley Street. And what does a private endocrinologist do for faltering growth? They provide growth hormone, and there is absolutely no improvement in the growth with this treatment. So he's at below the 0.4th percentile for his age. And he then goes to the endocrinologist here, and the endocrinologist here do some blood tests, and they show hypokalemic, hyperchloremic metabolic acidosis. And they show the urine here again with a cation gap and an inappropriately alkaline pH. And an ultrasound shows nephrocalcinosis and cysts. So this is a late presenting patient with variants in ATP6V1B1, which is the one that's most severely associated with deafness. So just to show you that even some of these recessive forms may present later. And if you have a patient with growth failure, I think it's always a good idea to get a basic blood panel that includes electrolytes and a creatinine, of course. So he commences treatment with citrate as an alkali form, and 8 months later, he is on the 9th percentile, from below the point falls to 9th percentile. And we could then also convince the private endocrinologist that maybe the growth hormone was not necessary any longer. So here's the long-term outcome with regards to growth for these patients. So this is only looking at the adults in our cohort. And obviously the average here would be a standard deviation of 0. And you can see that for most of them, they're below average, but they're almost all within the normal range, which the normal range being from -2 to +2 standard deviations. So final height is in the normal range, but slightly below average. And then this is looking at the kidney function, at chronic kidney disease, at glomerular kidney function, or eGFR. And you can see that in children 2 to 18 years here, there's already quite a substantial prevalence of advanced chronic kidney disease, mostly stage 2, a few stage 3. I think it was only 1 year with CKD4. And this is now in the adults, where there's very few patients now with normal kidney functions. The majority have CKD2 or CKD3. So there clearly is some impaired kidney function. This was the decline of eGFR in adulthood, which was roughly 1 ml per minute per year, which is actually, as I was very sad to learn, the decline also in all of us, that our eGFR apparently declines by that range in adulthood. So I am actually hesitant to calculate my own GFR right now. But nevertheless, if you compare our distal RDA patients to a control cohort, here the NHANES cohort from the US, then you can see that the prevalence of CKD stage 2 or higher is a lot more increased than in our distal RDA cohort compared to the normal population. Treatment. That was the most complicated part of the survey. A total of 34 different alkali preparations were used. So a quarter received bicarbonate, 40% received citrate, and a third roughly received combinations of both of them. We could not find any evidence that one or another form of this alkali supplementation was better. I think the key is you provide alkali, it doesn't matter in which form, as long as the patient likes it, can obtain it, and can take it. That's the key thing. So, and how much do I give? Well, the typical acid load that you get from your diet depends on how much meat you eat. The predominance of the acid load comes from animal proteins, which are high in cysteine, and cysteine are high in sulfur-containing amino acids, and these sulfur-containing amino acids are metabolized to sulfuric acid, and that's usually about 1 to 2 millimoles or milliequivalents of alkali per day. And then as children, they need to build a growing skeleton. Hydroxyapatite is an alkali, so that also generates acid, typically also around 1 milliequivalent per kilo per day. So typically, patients need between 2 to 3 milliequivalents per kilo per day of alkali supplementation. And that's represented here also in the genetic groups. But interestingly, and that I guess is the growing skeleton, more is typically prescribed in children than in older children or adults. Now, we assess the adequacy of treatment with two key factors. One is the plasma bicarbonate, which ideally we want to take as a trough level, so just when the next alkali supplementation is due, and with the urine calcium excretion. Acid can be buffered by the bone. I told you before, hydroxyapatite is an alkali. That's why it's very good at buffering acid. But if you do so, then you dissolve the bone. The calcium needs to be excreted, and the only way for the calcium to come out is in the urine. So if you have uncontrolled acidosis, you have hypercalciuria. So if we looked at plasma bicarbonate and urine calcium levels at the last follow-up, that's all we asked for in the survey, then you can see the 22 millimoles we took as the lower limit of normal. It's slightly different in younger patients, but we just took it as a one cutoff for all of them. Then you can see that the median plasma bicarbonate in the patients hovers around that, but that also means that almost half of all patients are inadequately treated with regards to plasma bicarbonate, have a level lower than that. And 15% of patients also had hypercalciuria. So in total, pretty much half of all patients were not adequately treated based on those two parameters at their last follow-up. So treatment is easy. You just provide alkali, but in practice, it doesn't seem to be that easy. Now, then we looked at whether a treatment actually matters. So we looked at the final height in the adults, or in greater than 15 years, and just checked whether those with adequate metabolic control had better height than those without. And as you can see, indeed, there is. So this was only based on the last follow-up. They may have had all fantastic control before, so there's obviously lots of confounders, but because of the large numbers of patients, there's a pretty clear statement to make that if you give better control of the acidosis, if you give better treatment, you make them grow better. And I think there's one boy that I just presented to you who had this enormous catch-up growth once he was started on alka supplementation, is a good example for that. With regards to eGFR, we also saw an improved eGFR with adequate control, but this was not statistically significant. Here comes, I think, my last case study. This is a 13-year-old boy, has known distal RTA, has this variant, homozygous variant in ATP6V0A4, so the recessive form, the one with the youngest onset, typically the most severe form of distal RTA. He has a long history of difficulties obtaining and taking medications, very difficult social background. And he presented acutely with vomiting and not tolerating his medications. And it turned out he had probably not been taking it for the last 4 weeks or something like that. And when he came to the local hospital, he was described as severely ill-appearing, cachectic. He could hardly move. He was unable to walk. He had a slurred speech. His polyuria was worsening. His weight was down by more than 5 kilograms, so about a 15% weight loss, and he had a severe acidosis with a pH of 7.09, a bicarb of 10, a potassium of 1.9. And the reason why I'm presenting this case is because I think as doctors, we are typically obsessed with normal numbers, and we want to, if we see abnormal numbers, we try to correct them as quickly as possible. So this boy received normal saline boluses, and there was added sodium bicarbonate and potassium in there. And you can see that with time over the day, his pH improved, his bicarbonate improved, but he also got severely hypernatremic. And this, of course, is because distal RTA is often associated with a urinary concentrating defect, a sort of secondary NDI. And if you give then hypertonic intravenous infusion, 0.9% saline plus sodium bicarbonate, and he puts out in hypotonic urine, you're going to make this patient hypernatremic. And this was quite marked. You can see there was an increase of 25 millimoles per liter over 15 hours or something like that. And with that, he got severely worse. Before he couldn't walk, now he can hardly lift up his head from the pillow anymore. He has new onset enuresis. He is confused. He doesn't know where he is. He doesn't know his name and anything. And he had an MRI which shows this rather dramatic osmotic demyelination that can happen. So lesson from this particular case is don't be obsessed with correcting anything too quickly, especially if abnormalities have happened over a long time. Like in this boy, he has not been taking his medication over 4 weeks. You can take your time in trying to correct it. Fortunately, and I think that's the benefit of working in pediatrics, their potential for recovery is enormous. And so with him also, he had a gradual improvement of his neurological findings. He's now oriented, he can walk, he can talk, and so on. So he has recovered really quite well from it. Okay, finally here, nephrocalcinosis and lithiasis. I told you acidosis leads to leaching of calcium from the bone, and that comes out in the urine. And virtually all patients have nephrocalcinosis that is typically already visible at diagnosis. Okay, and nephrolithiasis, so stone disease, is present in about 20% of patients, more in the SLC4A1. And I told you before, some of these patients present in adulthood or late adolescence with stones. And I think it's these many, many years of not being treated, of not having had any alkali supplementation because of delayed diagnosis, that they probably form these stones. Hearing, I think I'm going to skip out of in the interest of time, but it's much more common with the ATP6V1B1. That's the key message that I wanted to give here. So if we come back now to our question, I think this should be a very easy one. You can do the Slido. What's the best form of alkali supplementation?
The slide is coming, chaps. You'll be pleased to hear. I feel like a master and commander here. Is it up? Mm-hmm. It's up now, guys. So answer. We shall let you know. The quicker you answer, the quicker we move on to the next question, and the quicker you finish tonight, guys. Or the quicker we get on to John, actually. Let's make it a positive thing rather than finishing. Is that all right?
I cannot see the Slido. You tell me when I just...
What the answer says. It says 73% potassium citrate, sodium bicarbonate 50. Okay. But you said anyone, didn't you?
Yes, exactly. So I would say fine, all of the above. It doesn't matter. So if people have not been listening, I'm really disappointed. Yeah.
I think they're teasing you, actually.
we did present a patient with a potassium of 1, Detlef. I suspect that might have had some influence.
If it may have, yes, but I mean, for the chronic supplementation, I personally use potassium citrate as well, so that you can do potassium and alkali supplementation in the same medication. You don't have to give 2, but there's also many countries where potassium citrate is not available. And I mean, in some countries they use baking soda and just mix it with water. It doesn't really matter. The key thing is you're going to provide alkali. That's the most important thing. And whatever your patient likes, what he will take, that's what's good for the patient.
Oh, no, okay. And just to say, Detlef, they were listening. All of the above was not a choice, but the majority chose potassium citrate. So be pleased. You are a superstar.
So I apologize to you all. I'm really sorry. Well, I'm pleased, of course. Thank you. Okay, question 2, how much alkali supplementation is recommended? So this is a bit more tricky, and I didn't really go into the frequency of the doses, but hopefully you will recognize the dosage range. So you can start the Slido.
They listened 2 to 5.
Very good. You listened too. So very good. So 2 to 5. And the key thing is if you give it only as one big dose, let's say of sodium bicarbonate or potassium citrate, doesn't matter, then you will absorb that in your gut. Your bicarbonate will briefly rise very high, but once it rises above the threshold where your proximal tubule can deal with it, you will start losing it. You will start excreting it. So that's why it needs to be divided into several doses. And I usually say at least 3 doses. If I have a little infant that's newly presenting, and that may take even more than those 2 to 5, that may take up to 10 milliequivalents because you're still trying to get all his bones repaired, then I typically will add a little bit of citrate into each bottle of milk that he's getting, or for instance. But in general, I would say 2 to 5 milliequivalents per kilo per day, divided into at least 3 doses. There is, of course, now this new formulation called Sipnayal, which is a long-acting mixture of potassium citrate and potassium bicarbonate. these little granules, that needs to be taken only twice a day, but unfortunately is very expensive and not really available in the UK in general. So for all these other formulations, except perhaps also if you take the tablets, there is the Uracid K. That's also a delayed release formulation. So the adults, I think, use this more, and that only also needs to be taken twice a day. So I'm going to summarize here the golden nuggets, as my talk was supposed to be called. The key message is it's a treatable disease. I'm just referring to the acidosis, not to the deafness, obviously. That's more tricky. But the distal RTA is a treatable disease. Unlike other renal tubulopathies where you typically waste solutes, so that you waste potassium, waste sodium, something like that, and the more you give, the more it's just falling out. Distal RTA is different. It's a failure to secrete protons. And all you need to do is just to provide enough alkali to buffer those protons that have not been secreted by the tubule. The dose is the 2 to 3 milliequivalents per kilo. That's usually sufficient. 1 millimole of citrate is equivalent to 3 milliequivalents of bicarbonate based on the metabolization. If you give large doses, then you will have brief bicarbonate wasting. So you need to provide it in frequent doses unless you have access to these long-acting formulations. Treatment is easily monitored: plasma bicarbonate and urine calcium. Ideally, you want to have a trough value, so take the blood test right before the next dose is due. And a urinary concentrating defect, a secondary form of nephrogenic diabetes insipidus, is a common complication, and you really need to be aware of that, especially if you're starting to give IV treatments. And if you do well, if you do provide adequate treatment, your patient will be grateful, and it will result in improved growth and improved kidney function. Thank you.
Detlef, thank you. That was a fantastic run through. And this is a condition that, of course, we do see in adults, in adult life, where a proportion of them are these late diagnoses in children. So they're probably much more likely to have kidney stones, and the slower aspects of it, and probably they won't be quite so retarded in growth. We very rarely see deafness in them, but as they get older, an increasing proportion of them are autoimmune, with
yes,
often in
secondary forms of
often in association with Sjogren's syndrome. But I think the treatment principles are exactly the same. There's a question come through which kind of relates to this sort of patient. So here's a patient with stones; they're a bit acidotic. Don't sodium-based alkalis cause more kidney stones? Of course, having a high sodium output is one of the risk factors for kidney stones.
This is a theoretical consideration that obviously if you provide lots of sodium, that increases your urinary calcium excretion. But I think you also have to realize that distal RTA is in a way also a salt wasting tubulopathy, because you reabsorb sodium in exchange for protons. So if you're not secreting protons, you're also reabsorbing less sodium. So I don't think it matters clinically. And again, in this analysis that we did at the incidence of nephrocalcinosis or stones based on what kind of treatment the patients had, there was absolutely no difference. So it's a theoretical consideration that potassium may be better, but in practice, it doesn't seem to have any relevance.
It does involve this treatment with 3 times daily drugs, and it doesn't sound as if there's a quick way through that just yet. Very quickly, Detlef, one last question. You skipped over deafness. There's a terrible tendency to assume that all deafness is all ports. Here's a clear example where it's not. But why? Do we know why you get deaf with some?
Yeah, I mean, so the proton pump subunits, ATP6, V0, A4, and the V1, B1. So the same vacuolar proton ATPase is also expressed in the inner ear, and is very important to generate the acidic endolymph. And so that's why they get the deafness. And so no matter how well you treat their acidosis, it doesn't affect the deafness at all. That's completely independent of that.
Yeah, that's just fantastic. Detlef, thank you very much indeed.